Following Paul, a very tall man, a medium-sized man. So thanks very much indeed, Lynn, for the deep honour of doing the after-dinner bit. So when you're doing the digesting, you'll be doing it literally. And also asking me to follow on two fantastic talks this morning. I think you'd agree they were both marvellous. So I'm afraid it's downhill all the way. Now you've missed your opportunity. You could have made a run for the door after you had your lunch. And I'm very grateful for that you didn't. So as Lynn said, I've got this fancy title. I'm the Dean of Bioresources. So what's that all about? That's all about making samples from patients and normal donors and using them in research. That's essentially my job. So my job is to try and make that activity work really smoothly and to contribute to the fantastic research efforts that we heard about so wonderfully this morning. Okay. Now, like John, I spend quite a lot of time travelling. Does everybody recognise this particular place? This is King's Cross Station. I spend hours in King's Cross Station standing on the balcony waiting for my number to come up on those boards. Okay, sneaky trick, by the way. If you go on the balcony, you can skip into the train before everybody else. So I've shown this slide really just to illustrate a point, and that is to do with the way that we view populations in science and in trials. Okay, so first glance at this study, you've got a group of people. Actually, if you look at them, they don't look very, very dissimilar. There's not a huge amount of racial mix in there, actually. There's not terribly much of children. They all look about the same age. And that's the reason, because they're all commuters. They're all about to go home after a busy day in London. So they all look incredibly similar. But actually, if you begin to hone down on individuals, their differences appear again. Okay, so at random I've selected 3 people out of this crowd, who I don't know, instantly. So there's got 3 individuals. So in medicine we tend to look at whole groups, but of course those groups are made of individuals. Looking around the room, there's a lot of difference between each and every one of you. There isn't any identical twins, so Paul's point about your genome being different would have been shot to pieces if there had been 2 identical twins. He must have done a quick check before he said that. So you are individual people. And of course, as individual people, when you go along to see your doctor, you want to be treated in an individual way as a person, and where you are in your life, and your particular needs may be different. So this business about individualisation is very important to our healthcare system. But unfortunately, if you're talking about treatments, we cannot give absolutely individual treatment to every individual patient in many cases, because we don't have the drugs and tools to do that. So we do something called stratification, which is basically taking those people and lumping them into groups. So you hear a lot about stratified medicine. It isn't about individuals, it's about groups with similarities. The similarities in the way their disease presents, similarities in the way their disease evolves, and similarities in the way that they respond to treatment. So there's been a lot of investment over the last few years in this concept of improving therapy by targeting to individual groups like this. Now, Paul talked a little bit about the importance of the genome and how the genome can affect the way that we look and the way that we behave. But actually there are good examples in nature where things with the identical genomes look completely different. And the most obvious one, I suspect, is the caterpillar and the butterfly. The caterpillar has the same genome as the butterfly in which it evolves, but they look dramatically different. The parallel with us may be us during childhood and us as adults. We look different, our metabolism is different, the way we respond to medicines and treatments differs. So individualisation is not only between individuals, it can be between a person at different stages during their life. My own speciality in research is in paediatric oncology, the treatment of children with cancer. And the treatment of children with cancer is often very different from the treatment of adults with cancer, partly because of this evolution. Now the opposite can also apply. Things that look superficially similar can actually be very different. I've chosen Steven Spielberg in this case because Jeremy Corbyn is a bit too close to home. So you can look the same but actually have a completely different genome. So this is what they call the phenotype. We heard about genotype, we heard about genes. Phenotype is the way that you look, okay? The way those genes can manifest themselves, but also, of course, how the ravages of time can take its toll upon you. Okay, so those two concepts are actually very important when we talk about stratified medicine. Why is it important to understand genomes and phenomes? It's important because it does profoundly affect the way in which you can respond to treatment, as I said. And probably the best example is one of the oldest drugs in the world, right? One of the oldest drugs in the world is alcohol. We've been using alcohol as a civilization for many thousands of years. Now, most Europeans can consume alcohol to varying degrees, okay, but they don't have what a lot of Asian people do, which is facial flushing when they drink. And one of the reasons why alcohol is not so entrenched within some of these populations is because this is quite debilitating. This is not a trivial thing. So if you have a few drinks, you can go bright red if you're from certain parts of the world, and you have differences in the way that you metabolize alcohol. Now, alcohol is a drug, and therefore it's not surprising that when we come to drugs used in the medical context, people also vary an awful lot in the way they respond. And I think it was Paul who mentioned the warfarin example. So warfarin's rat poison. It's used for thinning the blood. Some people take a dose of warfarin and their blood is not thinned at all. Other people take the same dose and they can almost die of the bleeding consequences. Okay? So it's very important to understand those differences between people. This is another way of looking at changing, personalising, stratifying medicine. So why is this important? I've emphasised the importance for you as an individual patient, understanding the differences that may exist between other patients who look superficially the same. And that's the importance of giving the right drug, in this case, the right person, right time, right dose. But it's actually desperately important for the health service. I went to a very startling presentation by the man who's responsible for the drugs budget for cancer treatment in this country. There's a man who must have no conscience or sleep very well, because it is a really big problem. The big problem is that the budget for anti-cancer drugs is about just shy of £1 billion a year. You will know from the headlines almost every week how expensive the new treatments in cancer are. That budget is overspent by £300 million, and it is going up all the time. We simply cannot afford to give drugs to people who do not benefit from them. It does them no good, which is obviously important for them as individuals, but it also will bankrupt the health service if we don't get a grip on this. So stratification, not giving when it's not going to help, is as important to the health service as giving when it will help to the individual. And that's the side of the coin that sometimes gets forgotten. So not surprisingly, there's a lot of interest in getting this stratification right. Now, stratification depends on having sophisticated methods for testing the differences between individuals. Sometimes people would call tests biomarkers because they want to sound posh. But actually tests and biomarkers to me are the same thing. And you'll understand, I assume, what I mean by test. And we can test a whole load of things. So we can test genes, proteins, we can look down microscopes and look at structures. We can look at images that we produce of patients. X-rays, MRI scans, ever sophisticated ways of doing that. Okay, they are all tests. We can use various substances, we can use blood, urine, feces, anything that a doctor can get hold of, they will use in their tests. Okay? To be a good test, it has to be accurate. It has to have a low false negative rate. In other words, you don't want to be told something's positive when it's not, or vice versa. So false positive and false negative rates are really important when evaluating tests. And it has to be cost effective. You may have the best test in the world, but if it costs £50,000 every time you do it, the health service is not going to be able to afford it. And we heard this morning from John Simpson about how the DEC in Newcastle is helping to make those difficult calculations about what is and what isn't cost effective. Okay? So all of those things about biomarkers and tests is what I want to tell you about. And what has happened within the country is that the government and the funding bodies have spent millions of pounds on understanding the biology of stratification, the way in which it works between different groups and how that influences outcomes. But they haven't seen a lot of it pulling through to individual treatments. It hasn't got its way through to health service. And they were saying, what are the barriers towards that? And the initiative of the DEC and the node, I'm going to talk about in a second, is all about breaking those barriers down. John had a version of this which was lying on its side, and I've got one that's going from top to bottom. Okay. So you see at the top, you've got your genius scientists working in the laboratories like the one in Newcastle University. They work in institutes such as the one that I come from, the Northern Institute of Cancer Research, and they will study cell lines which come from patients, but are not very representative of patients. They sometimes use animal models. Okay, it's in a very artificial setting. And what they don't have the ability to do readily is to tell whether that's going to make it from that very artificial environment to the doctor's clinic. And the thing that gets in the way often is this business of commercialisation. So the way that the system works is that we do need input from industrial partners to help to take a test and take it out into the real world. That's how the system works. So if you go into the NHS, into a laboratory there, you'll see lots of tests which actually have come from companies. But companies are quite risk averse. They like to know whether they're onto a good thing or not before they invest lots of money. And often the gap is between the basic scientist and the company saying that's worth a punt. Then beyond that, we've already addressed this with John, is the business about giving those companies the evidence that they need to be able to go and convince the regulatory authorities or those hard-nosed commissioners that actually it's worth investing the taxpayers' money in their device, their test. So those two barriers were identified as being a major obstacle towards pull-through from basic research into clinical practice. John's already addressed the second of those with the evidence cooperative, and I'm going to address the first. And the other interesting thing that you may have noticed is that there is a big struggle at the moment between government departments about how much money goes to a variety of departments, a lot of shroud waving and high publicity comments going around. And the one thing that a department doesn't want to have at the end of any funding cycle is any money left in its kitty. Okay? And just before the general election, the Medical Research Council realised that they had £15 million left in the kitty. Terrible news. What am I going to do with it? If the new minister, whoever it might be, finds out, they're going to say, they don't need their money, they don't use it. So they thought, what can we best use this money on? Being the Medical Research Council also, they said it might be a good idea if we did something to do with medicine. That might be quite handy. And it might be handy if it looked like it was going to be something which was quite practical. So they thought, right, well, we've got this problem about stuff not going from basic research into clinical practice. Why is that? Well, the people who are doing this are the pathology departments, and they seem to have fallen on bad times. So they committed they got a report together which came out in August 2014, and it's all around something called molecular pathology. Now, what is your mental picture of a pathologist, I wonder? Is it somebody who, what is it? Somebody who looks after corpses. Corpses, right, okay. Any advance on corpses? What do you think? So yes, they do a bit of work on corpses. The surprising thing is that pathologists spend the vast majority of their time looking at biopsy material from the living. Okay, and any of you here have had a biopsy or a sample taken, a pathologist is the person who looks at it. They spend remarkably little time looking after corpses. And so this is one of the perceptions about pathology that I think we need to do something about addressing. It's a common one. So they looked at the pathology. Sorry, that's the wrong way. Yes. They looked at the problem of pathology. They took this report, which I'll refer to in a second, and they said, this is where we're going to put our money. We're going to do the bit between the basic research and the commerce, giving people confidence to get that extra bit of evidence that you need to make that happen. And they used their £15 million that they found behind on the bottom of the sofa, and they said to EPSRC, which is the science funding body, if you've got any problems like, we've got £2.5 million down the back of our sofa, we'll work together to initiate this new thing. There's also another thing about governments you may not know. They have a metaphor department, right? So there's these very clever people, mainly from Oxford and Cambridge, and they get together and they sort of say, well, what words haven't we used in combination recently? And they had catapults recently, and they have centres and nodes. We haven't had one of those for a while. So they came up with this idea of a node. All right. So a node is a centre of excellence in the pathology sphere. Okay. And they said, we're going to fund between 6 and 8 of these around the country. And we'll do a competition. The other thing these people do is they have their competitions, they announce them, they go on their Christmas holidays. And then they want the ribbon thing to be in on the 4th of January, which is what happens. And who does it working over the Christmas holidays? So lots of bad marks from home, putting together a bid. They wanted these notes to address the 3 things that came in that report that I mentioned. And they all, surprise, surprise, begin with P. Because pathology begins with P, and we all like to make things easy. The first P, is the pathway. Okay? The pathway between the basic science and the clinical practice, which I've talked about before. The second is proximity between research and clinical practice. When I first started training as a haematologist, there was absolute merge between clinical practice and research. I vividly remember people coming back from conferences in America with brand new tests for diagnosing a condition called chronic myeloid leukemia, a sophisticated way of doing this. Within about 3 weeks, that was in clinical practice, because the research side and the clinical practice side were interwoven. That has been lost. As the health service has become more target-driven, a lot of that activity has been driven out of the system, to our detriment, in my mind. Pathology suffers enormously from that problem, because what a pathologist has to do is to look at a bunch of slides under a microscope. If Mary can look at 50 slides, but John can only look at 40 in a day, a manager will come and ask why. It may be the case they're more complicated for John than they are for Mary. It may be that John is more conscientious than Mary. It may be that John is slow and lazy looking out the window. Okay, but they will be required to justify why they take the extra time. You can imagine in a system like that, the chance to be able to read papers, to do research, is lost. And that's one of the things that this node is meant to do, is to restore that. And of course, to help those people who have become de-skilled by that commissioning process to get re-engaged in the research agenda. And that's the third P, P for people. Okay. So we put in a bid, and I wouldn't be standing here today if we didn't get it. So we were successful, and the government awarded us a substantial amount of money to try and push this forwards, to get pathology out of the shadows and into the 21st century. The bid itself is slightly strange because it's based on 3 or 4 core projects, but actually the idea is to generate a system and infrastructure which enables us to nurse through as many as possible of these new discoveries in a variety of specialities. Our initial bid is around 4 particular things that we're very, very skillful on in Newcastle, several of which John mentioned this morning, and Paul also. The first of these is our expertise in liver disease, then in bowel disease, mitochondrial disease we've referred to already today, and because I put the bid together and it was my Christmas that was out the window, childhood cancer, because that's my own area of interest. Okay. In addition to that, we wanted to do some work on supporting biomedical engineering, which is where the science side, the EPSRC side comes in. And one thing that's happened over the last 15, 20 years is that biopsies have become smaller and smaller, which if you're a patient, you're very grateful for. So not so long ago, if you had a breast lump, you had a biopsy of that, the needle that was used was mighty big, okay? It's got smaller, and I'm not going to be subjected to one of these, so I can say I must hurt a lot less. I'm sure it does. So that's good news. The bad news actually is handling those samples is quite challenging. So we want our engineers to help with that. The second thing we want our engineers to help with is detecting tumour margins. Now, about 40% of all cases of cancer are cured by surgery, not by drugs, by surgery. And the best thing to do if you've got a cancer and it's amenable to surgery is indeed to cut it out. But actually, this poor old surgeon, I've spared you the picture of this because I knew it was going to be after lunch, the poor old surgeon is confronted with this mess in operation theatre, lots of blood, right? And they only have their experience, their sight, and to a certain extent their sense of feel to know where to cut the tumour, right? Let me take a very concrete example of a young man with a bone cancer, okay? Presents with a lump in the leg, has an X-ray, MRI scan, everything shows it's a bone cancer, it needs to be cut out. Goes to the operating theatre. My good friend and colleague Craig Durand He's operating on this leg. Imagine it in front of you. And he says, where am I going to cut? If I cut too much, I would lead to possibly an amputation in this young man. And that happens. I cut too little, and the cancer will spread. It's a really difficult problem. And just to highlight that, this is the sort of thing that will happen if he cuts too much, or he has to cut a lot. A child will have to live for the rest of their life with a prosthesis like this. This is a prosthetic company that's advertised this, and it calls it treatment success. Yes and no is what I would say. It's a success in terms of the best possible outcome for that individual. The true success would not be in that situation in the first place, would it not? Okay. So we've addressed the questions in the order which they appeared on the exam paper. Okay. So we did P for pathway to start off with, and now we've got P for proximity. So we're actually refurbishing a laboratory in the RVI. There's a fantastic routine laboratory there, and we're going to have a presence in the corner, as it were, with our research equipment, interrelating with clinical colleagues on a daily basis to reinvigorate that concept of research being integral to clinical practice. And we're going to have laboratories out amongst the basic labs as well, telling them how exciting and wonderful pathology is as a speciality, to drag people into it, to draw people into it as a future career. And the last P here is P for people, and we've got an online master's degree, so a lot of people want to upskill, but they can't afford the time off during the day, and their employer will not necessarily give it to them. So the idea of doing this online in their spare time is really attractive to people working in this and in other specialities. We're also very keen on recruiting bright young people when they're at medical school. Okay, the Jesuits have this idea many years ago, don't they? Give me a 7-year-old child and they're in the Jesuit clan for life. The idea is if you can get a biomedical student to do a degree, and a lot of them want to do a degree in between their medical degree, and you offer to feed them, they really like you. And they all think your subject is wonderful. So if you actually get them a bit of money so they can go down to the pub occasionally, or even go and get themselves a McDonald's, they will do children's cancer if that's your thing. They'll do molecular pathology, probably a percentage of them, for the rest of their life. So getting those people in early is really important. Last but not least, buying some time for consultants to become involved, to drag them away from that terrible pile of slides and tell the people, the managers, they don't have to see 50 or 40 anymore, they can just do down to 10 because they're doing some research and we're paying for the difference. So go away, okay? And I think John's labelled this point before, but we are the only place that's got both solutions in this pipeline, both a deck and a node. And actually there's an interesting geographical thing here about the nodes. They're all above Leicester, and that's really unusual. Most of the time this would be down in the Golden Triangle, as we call it, Oxford, Cambridge, London. Okay? So we're very privileged to have both those facilities, and we do think that is going to lead to rapid progress. I wanted to end on a concrete example, so that was sort of high-level stuff, and I wanted to give you a little flavour about how it might work in practice. And this is back to King's Cross Station, I'm afraid. So this is something I call screen and recruit, and it applies to a wide range of cancers, but I've chosen rare cancers in this example. What is the problem I would like to address? Rare cancers are not rare. Okay, what a strange thing to say. So if you look at this pie chart, you'll see that in the big slices, you've got lung cancer, you've got breast cancer, colorectal cancer, prostate cancer, stomach cancer, liver cancer, cervix cancer, esophageal cancer, bladder cancer, and the others. Okay? So those are the most common ones, and those are the ones where a lot of research effort has gone into trying to cure them. But the other group, 35% are in the other group. What sits in there is a bunch of tumour types which are characterised by this really good scientific paper that came out a few years ago, and they define rare as less than 6 in 100,000. But that still means that for those individual tumours, of which there are many varieties, there's around about 30,000 new cases diagnosed per year. So that's quite a lot, isn't it? So there's quite a lot of people sitting around Europe with a rare cancer, and it's a problem. Now the problem is, of the 186 different disease varieties with 4 million people alive with it today, the outcome for those diseases is actually overall worse than it is for a common tumour. So The overall survival is about 50% as opposed to 65%, which if you amplify it across the whole of Europe and the United States, of course, is quite a lot of people who aren't getting very good treatment. And the other thing about rare tumours, they tend to affect across the whole range of ages. So this is age across the bottom here, and this is incidence. And all the children's cancers, mercifully, are in the rare group. Right? Why is it a problem? It's a problem because nobody has the really easy opportunity of gaining expertise in treating them, because they only see one or two in the whole lifetime. How do they know how best to treat it? Now, people are getting together now with the internet, etc., and they share experience. So you're getting these virtual blogging sites, basically, of people saying, I've just diagnosed this, what should I do? All right? The other thing that is really difficult is organising clinical trials for these people, because they're dispersed across the whole of Europe. And also it's really difficult to engage the pharmaceutical industry because it's such a small market. So we're not doing a great job with these people. So how could we come across a solution? This is a traditional way that you do a drug trial. You identify a target, you identify a drug, and you go and find your patients. Easy. Easy if it's a common tumour. Not easy if it's a rare one, because finding the patients bit is really difficult. So the screen and recruit approach is to take the patients first, to produce a lot of characterisation about their disease, and in my case it's cancer, therefore it would be genetic characterisation by and large, put it through a whole range of tests, and then put it on a database and hope that someone's going to come along with a drug that they want to use in that group, which they frequently do. You've got them waiting for you. So as a drug company, that's really attractive. Okay. So the principle is you obtain consent from patients at diagnosis to take a sample and to reapproach them if a trial becomes available. We don't normally do that. We normally take a sample, that's it. One night stand, as it were. This is a lasting relationship between us and the donors of samples. We can go back to them and we can approach them to go onto trials. We screen them using genetic techniques. We retain some of the DNA, and also we invite pharmaceutical companies to look at that database and to select populations they would like to trial their drugs on. The advantage, the massive advantage, is the increase in speed of patient recruitment. Very rapid evaluation of drugs. Are they good? Are they bad? Can we pursue them? It reduces the trial costs, which can be astronomical for rare diseases, and it involves the members of the public. And I think I've noticed over the years a complete sea change in the way that we view patients and donors. We used to be very much, they were putty in our hands, there were people who gave us samples, we would say thank you if we were feeling particularly courteous that day, other times we wouldn't even bother to do that. Now we've got a relationship which is a more lasting one. We're asking people to tick a box that says, please, I don't mind, get in touch with me in the future, find out how I've got on, or if you've got a drug trial I'm interested in, please get in touch with me. And these sort of events really bring home that change in expectations. And I think for individual patients with these rare diseases, it gives them some degree of hope. Because a lot of people in these situations do feel completely disenfranchised and hopeless. Managing those expectations, of course, is a sensitive issue, because false expectation is also very cruel. So that's an intelligent, mature, grown-up, equal discussion that now occurs with people, which didn't used to happen. The sad fact is that many patients with rare cancers, if we don't do something different, will die waiting for a drug company to come along with something for them. So we do need a change. And the molecular pathology node is an example of how that sort of change can be brought about by using the techniques in the pathology laboratories. And basically it brings together what fantastic science we have in Newcastle, engineering and biomedical science, with the very excellent facilities that we have up the road at Freeman Hospital and other places like that. So hopefully I've given you some idea of what pathologists do. There's not just corpses, take that message away. And some idea of how we've got an exciting new partnership together with people like yourselves moving forwards. And I'll be very happy to take any questions.
Do we have any questions for Andy? Not a lot to digest. The question here.
most of us, we get stratification in it on age and gender. When are we going to move on from the age and gender to the one that you're talking about?
Yeah. I'll take the age side of it as a particular example. So I was associated with a remarkable woman called Binda, I forgot her first name, and her daughter presented at the age of 17 3/4 with a rare Ewing sarcoma, a rare tumour, and she was not allowed to go into a clinical trial because she wasn't 18. Now, if you'd have looked at, I've seen pictures of her, can you tell the difference between a 17 3/4-year-old and an 18-year-old? No, of course you can't. So these artificial barriers in terms of age are a real nuisance and something we need to address. It should be on biology and not on age. At the other end of the age market, a lot of trials stop at 60, 65. I am 60 and therefore I deeply resent it. I have what a 50-year-old used to look like a few years ago, is what I like to say. So the idea, it should be on my biology, it should be on my ability to take whatever treatment is available. So age, and I think it taken as red gender, should not be the criteria used for stratification. We use it because it's the most easy and obvious thing to look at. It is a surrogate for some things, but not a perfect one by any stretch of the imagination.
Any other questions?
Debbie Binner it was, just remember.
Okay, well, people will have questions as we know, but we'll record those later, so thank you very, very much, Andy. That was absolutely